the study that we did, which is a CALGB 40101 study, we looked at patients who had 0 to 3 positive axillary nodes. In fact, about 90% of the patients had node-negative disease. And we looked at standard chemotherapy, which was cyclophosphamide and doxorubicin, versus single-agent paclitaxel therapy, with the hypothesis that if paclitaxel was equivalent to AC, it would be a much less toxic regimen, both for short-term toxicity and long-term toxicity. We were also interested in exploring the duration of therapy, so patients either got 6 cycles of one of those 2 regimens or 4 cycles. Over 3,800 patients were enrolled in this study, so it's a large study. Randomizations, I think, were well done, and the groups were quite equivalent. And what we found was 2 important findings. First of all, 6 cycles of therapy was not superior to 4 cycles of therapy in any of the subgroups. And you look around and still many regimens, even for node-negative disease, are using 6 cycles of therapy, and toxicity is clearly worse for 6 cycles than 4. And I think we can now say confidently that 4 cycles of therapy is enough for these patients. Secondly, we were interested in whether paclitaxel was equivalent to AC, and it was pretty clear in this study that it was not. All the statistical analyses we did showed that we could not say paclitaxel was equivalent to AC, and so AC is clearly still the winner in that regard, and goes back to a tenet that we've held now for 40 years, that combination chemotherapy for these patients is essential. And that was really too bad because, in fact, as we would expect, AC was more toxic, there were more leukemia deaths in the AC patients, there were more cardiac deaths, but it's still a better regimen overall.